Thank you, Dr. Meyer. And I'd like to thank yourself and Dr. Pizzoni for presenting me with the opportunity to present this abstract I consulted on with some of my residency colleagues from St. Luke's. The outline will be similar to most of the presentations you've seen over the last number of days. Just to provide some background, the incidence of aortic regurgitant lesions in the end-stage renal patients on dialysis is estimated to be significantly higher than that of the general population. There had been an article by Dr. Steinbow and his colleagues in the mid-90s which estimated an incidence approaching, or prevalence approaching 40%. While the pathophysiologic mechanisms for stenotic and sclerotic lesions is inherently linked to disorders of calcium and phosphate homeostasis due to synthetic dysfunction within the failing kidney, the mechanism behind aortic regurgitation has never clearly been delineated in the literature. And furthermore, we wish to ascertain whether or not the different types of vascular access used in common clinical practice for dialysis patients affected this incidence or prevalence of disease. We performed a simple cross-sectional analysis of 53 patients from a single dialysis center associated with a hospital. All patients had been on hemodialysis across 6 months, or for at least 6 months I should say. And we performed a multivariate logistic regression analysis on the data. To briefly review the types of vascular access currently in use and commonly in use, the first and most common is the simple arteriovenous fistula, where a direct connection between the artery and the vein is created. There's also the synthetic vein grafts, or synthetic grafts I should say. So a plastic PTFE graft is used where anatomy or a number of patient factors don't allow for direct anastomosis of the artery and the vein together. And it's the graft itself, not the distal vein, that's cannulated during dialysis in these patients. The third major type of vascular access that we see is just the simple tunneled central venous catheters, the permacats. So in our limited study, what we found were that the prevalence of aortic regurgitation amongst those patients who had synthetic grafts was significantly higher than those who were getting their dialysis via an AV fistula. We calculated an odds ratio of greater than 9, obviously a broad confidence interval given the limited data that we had available to us. The numbers were statistically significant. We did not find any other significant differences in the prevalence of valvular lesions between the varying types of vascular access in the patients that we analyzed. So here's graphically the results. So as we discussed, there was certainly a higher percentage of the graft, or the patients with the grafts in situ who had aortic regurgitant lesion. Interestingly, the patients who were receiving the dialysis via the catheters, these central venous catheters, also had a greater incidence of aortic regurgitation compared to the fistula population. These are the rest of the results in full, and like I said, we're dealing with some limited numbers. It's a small study, just 9 patients with synthetic grafts. And while the regurgitant lesion in the aorta we talked about, interestingly what we found in our population was, surprisingly, that both stenotic lesions of the aortic valve and the mitral valve were lower than one might expect in this patient population. So, the reason we chose this particular patient population is because they represent a group at increased risk of cardiovascular mortality and cardiovascular death, both related to coronary artery disease and significant valvular disease is associated with high morbidity and mortality in this group. Furthermore, significant valvular lesions potentially requiring operative intervention is a significant undertaking in this high-risk group. There are some interesting hemodynamic variabilities between synthetic grafts and arteriovenous fistulas, whereas the diameter of the graft will remain fixed for its lifetime. The distal vein with the arteriovenous fistulas will slowly increase in diameter over time. Both groups obviously have increased cardiac output and decreased systemic vascular resistance as you're bypassing the arteriolar bed. But there are subtle differences between these types of vascular access. And this is one of the hypotheses for why the prevalence of these lesions may differ between the groups. It's been previously documented that arteriovenous fistulas are associated with lower all-cause and cardiac-specific mortality, and whether or not this is another confounding factor or whether or not potentially that these findings could represent another confounding factor in this remains to be seen. And as I mentioned in my opening, while the sclerotic and stenotic lesions can presumptively be explained by disorders of calcium and phosphate homeostasis and calcification of the valves, the same isn't true for aortic regurgitation. There isn't that much data out there to explain why the prevalence is higher amongst this patient population. It's certainly a limited study. It's a very, very small sample size. We just have one dialysis centre. We intend to expand it beyond that with our further analysis. If we're to attribute the majority of the differences to hemodynamic differences between grafts and fistulas, what doesn't quite fall into place for us is that the prevalence of aortic regurgitation with catheters sits somewhere between the two. And these patients with catheters in situ who have been on dialysis for over 6 months probably certainly have a greater degree or greater risk of infectious complications, which may lead to valve seeding and damage, which may explain this difference. And that might be another factor that at play to why both the synthetic grafts and the catheters together have a higher incidence of aortic regurgitation. We didn't grade the severity. We just noted the presence or absence of any aortic regurgitant lesion, anything from mild to severe, as part of this small lesion. And moving forward, in order to make this data potentially more clinically relevant, the severity of the lesions, as well as assessing for symptomatology, is going to be important. In the oliguric and anuric patient population that we're dealing with, volume status is far more variable from day to day than the general population. So when we're analysing the data, none of the patients included in our study had missed any dialysis sessions in and around the time of their echocardiograms. But the volume status needs to be controlled, so we're trying to get potentially prospective echocardiographic results for patients who are as close to their dry weight or as close to having their previous dialysis session as close to the dry weight as possible. And there's an inherent selection bias in the cross-sectional study for patients undergoing routine echocardiography, which in and of itself is a misnomer because no one should have a routine echocardiogram. There must be a clinical indication, so that could possibly explain the higher rate of valve lesions in this patient population. Most of these, I think I've mentioned that we'd like to move forward, expand our patient size. We have access to other dialysis centres affiliated both with our hospital and our hospital network, grade the severity, and as well to document any history of endocarditis, given this patient population's high risk for infectious complications over time. Thank you very much.
Thank you, Dr. Gordy. That's been a very interesting presentation. Any questions from the floor? I have a few. The most interesting part of this is that the hemodynamic differences between the different access modalities. Now, even though the arteriovenous graft fistulas, you said, as we know that the main modality is definitely do you have any actual data? I know it's a small series, but looking at the cardiac, the flow through the different conduits to know if that is really true. As you know, our AV fistulas tend to be self-limited over time, and then the patients have to go the next step to a synthetic graft. So one question is, do we know anything about the actual flows through these different modalities? And two, does the duration of the time patients are on dialysis, can that be reflected in your results as well?
Okay. They're two excellent queries, and they're things that we kind of thought about as well. There's some data there. Now we don't have that data to summarize, but there's some data initially, that perhaps that the amount of instrumentation that a fistula or a graft undergoes may affect the incidence of valvular lesions in this patient population, as well as the prevalence and incidence of pulmonary artery hypertension. And there were some theories put out for those. The duration of time that patients are on dialysis certainly needs to be accounted for. We don't have it in our data. From that centre, we were only able to identify those patients when they started at that centre, but many of the patients, because the centre was relatively new, had transferred from another centre within New York and come down. So moving forward, it's certainly going to be an important thing for long-standing dialysis patients as opposed to those newly on dialysis. You'd expect that the prevalence of valve lesions would certainly be different.
Well, thank you. Excellent presentation.
Thank you.
And thanks to the